Welcome to our video on aortic dissections. Let's begin. We'll discuss the definition, classification, pathophysiology, risk factors, clinical presentations, diagnosis, and management of aortic dissections. Aortic dissection is a tear in the tunica intima of the aorta. The tear extends down the vessel without disrupting the media and adventitia. The classification systems for aortic dissections include the Stanford and DeBakey. We'll discuss the Stanford first. There are two broad categories of dissection, type A and type B. Type A involves the ascending aorta, while B includes the descending aorta. If both the ascending and descending aorta are involved, then it is a category A. Another classification for aortic dissections is the DeBakey, in which there are three categories. Class 1 involves the ascending and descending aorta. Class 2 only involves the ascending aorta. And finally, Class 3 is the descending aorta only and corresponds to the type B dissection. Let's move on to the pathophysiology. The inciting elements that lead to an aortic dissection are aortic wall inflammation, which leads to apoptosis of the smooth muscle cells. This causes weakening of the media and elastin disruption, which cause the intima to tear. The intima tears because it is no longer supported by a strong tunica media. The force of the blood that continues to flow can extend the tear down, creating the flap. This tear can interfere with branches coming off the aorta and disrupt blood flow to various organs. Before I go any further, I'd like to mention that this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of aortic dissection. We will use this image to reinforce the pathophysiology. The already weakened tunica media decreases the support to tunica intima, which leads to tearing of the intima. Blood flow extends the tear, leading to a true and false lumen. The blood flow now flows on both sides of the tunica media and intima. In the distal vessel, another intimal tear may occur, which allows for re-entry to the true lumen after the blood has passed through the false lumen. Risk factors of aortic dissection include pre-existing conditions with degeneration of the tunica media. Examples would be connective tissue disorders such as Marfan syndrome or Ehlers-Danlos, atherosclerotic disease, and tertiary syphilis. However, the most common risk factor is hypertension. We'll add a note here regarding deceleration injuries and associated aortic dissection. This is not from the degeneration of the tunica media or high blood pressure. When a patient experiences a significant deceleration in the horizontal direction, the proximal aorta is prone to tearing near where the left subclavian artery branches off the isthmus. It's the tethering of the ligamentum arteriosum which makes this site prone to the shearing forces. Let's do a quick review. A CT scan demonstrates an aortic dissection consistent with this diagram. What kind of dissection is this? Using the Stanford and DeBakey classification systems. The torn intima is involving only the descending aorta. This means we are treating a patient with a type B dissection, according to the Stanford classification, and a type 3 in the DeBakey. The most characteristic feature of aortic dissection is ripping or tearing chest pain. It frequently radiates to the back or shoulder. Patients may also present with syncope due to the disruption in blood flow to the brain. Hypotension and tachycardia suggest there may be an ongoing bleeding from the dissection. Since the dissection can disrupt branches off the aorta, the subsequent territory supplied will show signs of disruption, such as acute kidney injury, cardiac tamponade, pleural effusion, aortic regurgitation, and pulse deficits in extremities. The pulse deficits would manifest as a difference greater than 20 millimeters of mercury in systolic blood pressure between left and right arms. Let's do another question. How can an aortic dissection lead to acute kidney injury? Here we have the aorta and its branches. And here are the kidneys with their blood supply from the renal arteries. So if there is a dissection here, it will disrupt the blood flow to that kidney, leading to ischemia and evidence of acute kidney injury. The initial imaging obtained in a patient with tearing chest pain is a chest x-ray. If there is a widening of the mediastinum on the chest x-ray, then confirmatory imaging is required, though it is present in 60 to 90% of patients. It can be confirmed with a transesophageal echo, CT with IV contrast, or MRI with gadolinium. This is a chest x-ray showing a widening of the mediastinum highlighted by the pink arrow. We will use this algorithm to further elaborate on the evaluation and management of aortic dissections. The initial workup for chest pain concerning for aortic dissection include CBC, BMP, troponin, ECG, and chest x-ray. If there are ECG findings suggested of ischemia, such as ST segment elevation or hyperacute T waves with elevation in troponin, we should consider acute coronary syndromes. A widened mediastinum on chest X-ray further suggests aortic dissection. However, if there is a history of frequent emesis or endoscopic procedures, we should consider esophageal rupture. If there is suspicion of aortic dissection and the patient has chronic kidney disease or acute kidney injury, then only a transesophageal echocardiogram can be done to confirm the diagnosis. If the patient's creatinine is within normal limits, then transesophageal echocardiogram, CT with contrast, or MRI with galactium can be done. MRI is unlikely to be accomplished in the emergency setting, and only stable patients should be sent for a CT scan. If the ascending aorta is involved, then it is a type A dissection. If not, then type B. This is a CT scan that shows thoracic aortic dissection as outlined by the red circles. We can see the false lumen that has been created by the intimal tear. Let's try a question. Why would a patient with an aortic dissection have ST segment changes and an elevated serum troponin? ST segment changes and elevations in serum troponin are suggestive of cardiac ischemia or a myocardial infarction. While myocardial infarctions are frequently caused by clots in the coronary vessels, they can also be caused by aortic dissection if the dissection extends through one of the coronary vessels. Surgical repair is used in all type A dissections and is emergent. Non-emergent surgical repair is used in type B dissections that fail medical management. Surgical repair include open or endovascular. Medical management involves lowering the blood pressure to decrease the force exerted on the tear. Beta blockers are the treatment of choice because they lower the blood pressure without inducing a reflex tachycardia, which would increase the stress on the wall. Potential agents include esmolol and labetalol. Coming back to our algorithm, management of type A dissection is emergent surgical repair, while type B is medically managed with blood pressure control. If the medical management of type B dissections fail, then surgical repair is indicated. Let's end this lecture with a question. A 57-year-old male presents to the emergency department with a chief complaint of severe chest pain. Patient reports that pain started 20 minutes ago while driving to work and is the worst pain of his life. Past medical history is significant for hypertension and stage 4 chronic kidney disease not requiring hemodialysis. Vital signs include a blood pressure of 98/45, pulse of 120, respiratory rate of 18, and oxygen saturations of 94%. He's diagnosed with aortic dissection. The patient fails first-line treatments and is then taken to the operating room for definitive repair. What would be the expected characteristic of the dissection on imaging this patient received? A. Involvement of the celiac trunk on transesophageal echo. B. Involvement of the brachiocephalic artery on transesophageal echo. C. Involvement of the superior mesenteric artery on MRI. D. Involvement of the left subclavian artery on MRI. E. Involvement of the celiac trunk on CT. This patient has a dissection where first-line treatment failed and was taken to the operating room. This means the patient had a type B dissection, which is first medically managed. If it's a type B dissection, then the ascending aorta cannot be involved, which eliminates B and D. Notice that the patient has stage 4 kidney disease. This means he would not have a creatinine within a range to tolerate CT, which uses IV contrast to diagnose dissection, or MRI with gadolinium. A transesophageal echocardiogram would have been used in this patient. This eliminates answers C and E, leaving A as the correct answer. And that concludes the section.